Hi, everyone. I'm just going to try a face-to-face video so we feel like we are all talking to each other, at least I'm talking to you. Anyway, just wanted to say good work on getting through week 2. I know some of you are probably having a break now, so that's good, and then you'll be starting up again. The wiki groups are doing a really great job of disseminating the reading, so I hope everyone is taking advantage by reading the contents that's being put up, and definitely, again, as I said, a really good document for studying for the exam or for quick paper referencing. Um, Posts. The post covered Medicare. So Medicare, I'm just going to talk about a few topics just to help reinforce some of the learning. Medicare is a term we often use to describe the Canadian healthcare system, but it's also used in the USA, and it's a term used to discuss a health insurance scheme that's provided to people over the age of 65. Of course, we know in Canada it's what we use, a descriptor, what we use for everyone gets Medicare. The principal objective of provincial and territorial medical systems is to deliver medically necessary or medically required services. So those are the terms they use, necessary or required, on a universal basis without any kind of financial obstacle. So timely access to medically required or medically necessary services is a different situation, which is considered a barrier to the of service. It's sort of a shift, I guess we'll call it. So a shift in financial barrier that may be experienced by Americans. For Canadians, the access is or the barrier is an access barrier, which is really highly criticized by policy experts and also the public. But I don't know that it's always an accurate assessment of the functioning of our healthcare system. I think that that's a very difficult topic to get into. So we won't really get into the access aspect of Canadian Health Act. When we discuss sustainability, we should be talking about the ability to continue the status quo. So I know the Post talked about the sustainability of Medicare with specific focus on Canadian Medicare. So there are many skeptics who do not feel that the Canadian health system is sustainable. This is in part due, it's also a very complex topic, but it's rising cost of chronic disease. So we think about people with diabetes, congestive heart failure, COPD, those chronic diseases that often have exacerbations that result in hospital stays that can be quite expensive and frequent use of emergency rooms based on those people with those types of chronic diseases. There's also a continued focus on an expensive acute care system with our healthcare system, and increases in technology and advancement are often related to the acute care sector. And those can increase costs, not just because the cost of the advancement or the tool or technology we're using is expensive, but also because it creates a longevity in lifespan. And so the longer people live, the more they're going to use healthcare. So just this sheer factor of increasing lifespan is a cost that impacts our ability to sustain healthcare. So all of these things are happening without a real aggressive reform in primary healthcare. So this means that people who are policy experts in health in terms of examining the Canadian healthcare system are really concerned about the ability for us to continue this, sustain the system the way it is today. And another factor that I actually didn't even get into with this was the whole idea around the rising, what we call the silver tide, or the number of people who are older. And we're going to see a huge, massive increase in Canada of the percentage of the population, that's over the age of 65 that we've never seen before. So we know that the most expensive care that anyone receives is in the first year of your life, especially if it doesn't go well, and in the last years of your life. And it used to be the last couple years of your life. It might now be the last 10 years of your life because of these advances in technology that people are able to live with a chronic disease for a lot longer. Okay, so Greg Marchildon used to be a U of R public policy professor who I think is a very intelligent person who's written lots of reports on Canada as a country specific to healthcare. And so he states that the Canadian healthcare system is best described as an amalgam of public, mixed, and private systems of healthcare. Many of us don't think of Canada's healthcare system that way. We think of it as only as a public. So the universal part of our public system is made up of 13 separate single-payer universal schemes, which would be our 13 provinces and territories, and that these schemes are all held together by a broad standards set out by the Canada Health Act, which we all discussed in this unit this week. And this Canada Health Act requirement is enforced by federal transfer and has potential penalties. So that's the mechanism by which the government of Canada or Health Canada, feds, support and also protect the principles of the Canada Health Act at the provincial level. So they basically hold all the provinces and territories accountable to meet the principles of the Canada Health Act. So public coverage is really deep. There's no user fees, but it's also very narrow in that it's the core of Medicare really remains hospital and physician services only. Doesn't include a national pharmaceutical program. It doesn't include a lot of outpatient clinic and programming. And so the provinces are really left to figure this out as well. And so that can create a view of potentially some inequity or a patchwork, I guess, of what is offered where. So it can give the impression that we're not being universal, but in fact, we are universal on what needs to be covered, which is hospital and physician services, maybe not with primary health care. So the influence of policymakers, which is policy is really what this course is about, at its core, is often quieted by a more powerful influence, and that influence is people. So constituencies, which are often used in political terms, which means people who vote, can be very persuasive and have power in numbers and may sway decision making in their favor, though not necessarily to the best interest of everyone else. This is where special interest groups and organizations can have a real profound impact, which is why we do so much work in this course around CNA, because that's our group, that's our voice and our influence on the policy agenda. So as you saw in the video I posted about refugee healthcare, the use of this type of media by the public sent a strong message about what Canadians value. And this may have helped determine the Liberal government in deciding what changes to make. So if you've not already watched the student presentation on refugee healthcare, I really encourage you to do that. So it was a really well done presentation, and it very articulately explains the differences and even what that whole system is about, because I'm sure many of you might not have known. Okay, so good job. I think we're rocking and rolling in this course so far. Next week is ethics. I hope you guys all enjoy this week. It usually is kind of a fun week for the students to do. So Wiki Group, I just want to reemphasize, you do not need to summarize the case study. Read it, because then you'll know what the presentation group is talking about, but you're not summarizing that, but you do need to summarize the ethical theories that follow. Presentation people, I hope you have a really good time with it. Posts. The note I want to say about the posting group. So there's some easy ways to fall into expected answers with this post. I really want you to consider the social context of both the mother and the child. Keep in mind not just an altruistic response, but a realistic response. And I also want you to consider that this is an ethical dilemma, which is why it's in the ethics unit. And an ethical dilemma means a choice between two difficult options, and sometimes it doesn't really feel like either option is good, but you have to make a choice. So if it seems like an easy slam dunk decision, then you've probably missed what I'm expecting you to do, which is to dig a little deeper and consider, weigh out the options that you have. You don't even necessarily have to make a decision. Just tell me, what are my options here with this situation, and what do I think, and what are my resource, or what are the resources I'm using, which I hope is the CNA Code of Ethics, because I think I asked you to do that. But even you can talk about your personal values or your personal perspective. It doesn't matter. But I want you to really, don't just give a simple answer that we all know you're going to say. Go beyond that. And so just, I guess my closing statement for this week is, for looking into ethics, is remember, it's not always black and white, and in nursing, we're always working in the gray. So good luck. Can't wait to see what you have. Please contact me if you have any questions. Okay.